The chair for today is Andrea Croft. Andrea is a lead advanced nurse practitioner and trustee with Thrombosis UK. After inheriting the management of the hospital warfarin clinic in Bridgend General Hospital in 1995, she developed an interest in anticoagulation. And since 2002, Andrea has pioneered and championed the need to manage all hospitalised patients appropriately, keeping them safe from the associated risks of developing a hospital-acquired thrombosis. Since 2009, Andrea has held the role of HAT project lead at the Abertour Bro Morgannwg University Health Board, where in 2015, 3 of the hospitals in Andrea's health board were recognised as thrombosis exemplar centres. So without delay, over to you, Andrea.
Oh, thank you very much, Jo, and thank you for that nice introduction. I'm no longer with Abertawe Bro Morgannwg University Health Board. I'm now with Cwmtaf Morgannwg University Health Board, and I'm the thrombosis lead in the Princess of Wales in Bridgend. So without further delay, this morning, the aim is that myself and my colleagues, Marilyn, Rees, Professor Simon Noble, and Christine Wellborn are going to share with you what's been happening in Wales over a period of about 8 years, just to give you an update of where we've been and where we're going. So hopefully the session will go to time, might finish a little bit earlier, and if it does, then I believe you have a break after our last session with Christine. But I shall continue now. If anybody's got any questions, if we leave them till the end of the session, unless it's a really burning question, and you can send a message, which I'm sure Jo will pick up for the moment, and then I'll pick up afterwards. But thank you very much. So I'm just going to share my screen. Okay, so as Jo explained, my name is Andrea Croft. I'm a lead advanced nurse practitioner in anticoagulation, and I'm the Wales Nurse Director from Thrombosis UK. I have nothing to disclose, just inform everybody of that. So just to start off with a little background. So in 2012, approximately 900 people in Wales were reported of dying from venous thromboembolism related causes. Not all of the deaths were avoidable, but many may have been. And many survivors of deep vein thrombosis can suffer long-term physical and psychological effects. Most cases of VTE occur during or following a hospital admission. So VTE, and VTE collectively would be DVT and PE, can have a long-term effect on survivors. Up to 40% of patients can develop a chronic condition called post-thrombotic syndrome. Research completed in Wales has identified psychological complications with some symptoms suggestive of post-traumatic stress disorder. Most cases of VTE occur following a stay in hospital, and these are known as hospital-acquired thrombosis. And most of these cases can be prevented with simple preventative measure, an early risk assessment, and appropriate thromboprophylaxis. And what I'm explaining to you here, this statistic and these background, this is what we've known in the United Kingdom since, well, work started approximately 1995 with work to reduce the hospital-acquired thrombosis. So hopefully everybody is familiar with what I'm sort of sharing with you now. So since the publication of the recommendations of the Welsh Assembly Government one-day inquiry into hospital-acquired thrombosis in 2012, NHS Wales clinicians and Welsh Government have been working together, originally supported by 1,000 Lives and Thrombosis UK, and now 1,000 Lives have come to an end, so our main support is with Thrombosis UK. And this is to improve the situation for patients admitted into Welsh hospitals. With the support of Welsh Government, we can evidence that health boards are not only collecting and analysing data on patients who may have had hospital-acquired thrombosis, but also identify where there have been potential system failures and implement improvement measures. There's still some way to go, particularly in identifying patients who may have died in the community, and it's vital that good relationships and reporting mechanisms are developed with medical examiners. And the medical examiners in Wales came into post, they were due in post in 2020, but due to the pandemic, it was sort of between 2020 and now 2022. So it's vital that we have good relationships with the examiners. So the national recommendations that came in 2012 following the one-day inquiry were recommendations to NHS Wales to encourage improvement. And these recommendations were making reporting of hospital-acquired thrombosis a Tier 1 priority, mandate risk assessment and thromboprophylaxis, develop a standardised HAT rate, undertake root cause analysis of all potential HATs, and increase clinician and public awareness. Now, in Wales, we had a HAT as a Tier 1 priority, and that meant that health boards had to achieve these standards as a priority that had been put in place that health boards had to achieve. There was no financial incentive. It was purely down to, well, for thromboprophylaxis, a carrot and a donkey. In England, they had the sequin payment system, where if health boards and trusts didn't achieve the required uptake of risk assessment on admission, health boards were originally charged, and then they were paid for the number of patients, the percentage of patients that were risk assessed. So it was a slightly different system. And to be quite honest, I think originally it looked as though the sequin payment would work better, but I think the carrot and the donkey was more successful because we didn't have that financial sort of incentive in place. So the All Wales HAT Steering Group, this was a group that was set up to implement the recommendations made by Welsh Government. There was a number of people in Wales in 2012, myself, Marilyn and Simon Noble, Professor Simon Noble, who are going to be speaking to you today. We were already members of a group that were doing everything we could to increase the uptake of thromboprophylaxis. So when the 2012 one-day inquiry took place, it was a huge bonus for us in the group that we were in, and it was a huge bonus for patients in Wales, because suddenly we had something that we could actually physically engage with health boards to make sure that patients were risk assessed, treated, and ultimately kept safe from developing clots. So the group includes a multidisciplinary membership from all 7 health boards and Velindre Cancer Care Centre in Wales, and it includes clinical trustees and patient representation from the renowned thrombosis charity Thrombosis UK. So we've got a really widespread representation on that group, and what's particularly important is that every single health board in Wales and Velindre is represented on that group, so we all have a voice, and any decisions that are made by all of those representatives. I do apologise, I've got a cold, so if I keep coughing or sniffing, I'm very sorry. So the steering group agreed the definition for hospital-acquired thrombosis and a methodology for collecting potential HAT incidents. And importantly, they recommended changing the reporting measure from a HAT rate to HAT incident. And this provided an emphasis of potential harm to individual patients and proved more beneficial in engaging NHS staff. So by saying, yeah, we have 5% of patients who have developed a hospital-acquired thrombosis, it didn't sort of personalise it. But if we said we have 5 patients who have developed a hospital-acquired thrombosis, it's putting the emphasis on the person rather than the percentage. And we found that this was more beneficial because it actually personalised the figure. So the group also developed and agreed the risk assessment process, working in collaboration with the All Wales Medication Chart Group. And this resulted in a new section being added originally to the front page of the All Wales Inpatient Medication Chart that made it easier to ascertain whether a patient had been risk assessed and whether the correct thromboprophylaxis had been prescribed. And this measurement, or a measurement, is taken through the hospital thermometer by our pharmacy colleagues, and they measure the uptake of the completion of the VTE thromboprophylaxis section on the medication chart, and they report that on a monthly basis. So we can see at a glance how every health board in Wales is getting on, which is really useful. So not all VTEs can be avoided, as we know, and the group wanted to create a measurement system that would identify those potential cases that could have been avoided if the correct steps were followed. And therefore, a screening tool was included in the reporting mechanism. And I'll show you the screening tool in a moment. So potentially avoidable HATs were identified by asking two simple questions. Was a VTE risk assessment carried out? And was the appropriate thromboprophylaxis given? If the answer to either question was no, then the case needed to be investigated further. In 2015, the method of recognising potential HATs was linked into Welsh Government's Tier 1 reporting mechanism, where health boards were required to report the number of potential HATs identified on a monthly basis, the number of HATs that were potentially avoidable on a quarterly basis, and lessons learned from a subsequent root cause analysis. And this was the root cause analysis tool that was developed. So it is quite small, and this is an actual one that, that I sent through in 2018 when I was with ABMU. So as you can see, on the left-hand side of the screen is the monthly number of VTE cases associated with a hospital admission or up to 90 days post-discharge. So any patient who developed a VTE during the time from admission to discharge or from discharge up to 90 days, those figures were collected and then we put them in monthly. So we have a number of VTEs that were reported that were potential HATs. Then we took the notes for those patients, and different health boards have different ways of collecting the notes. And the way that we got that figure was done in the same way, and it was agreed that we would work with our radiographer colleagues, and there were keywords and phrases that were put into radiological reporting, and the keywords were things like DVT, PE. They were then picked up, added into, looked at the patient's hospital admission, or if it was up to 90 days discharge, and then that generated these numbers. So then on the right-hand side of the screen, you can see that we have Q1, Q2, Q3, and Q4, which relates to the scheduled dates in the box above. We could see how many notes were missing. We could see of those notes that were remaining, minus the ones that were missing, had an actual root cause analysis completed. From those then, following the root cause analysis, how many were actual number of potentially preventable HATs, and then the number that that weren't considered to be a potentially preventable HAT. So as you can see, at that particular time in that year, there were 7 potentially preventable HATs out of a total number of, I think it's 137 patients that were reported as potentially having a hospital-acquired thrombosis. So I hope that makes sense. And then at the bottom, we could put in then sorry, I can't read this. Lessons learned. And the lessons learned was really important because we brought the lessons learned back to the steering group, and we usually met on a quarterly basis, and we would share all of the lessons learned and share common themes, and then look at ways of addressing the situation that we found was common across Wales. So the greatest improvements have been made in the promotion of reporting, reviewing and reacting to potential HAT incidents. Every health board now collects and reports potential HAT incidents to Welsh Government. They also report how many of these incidents have been root cause analysed and what lessons have been learned. And the analysis has shown that this has had effect on the increasing number of assessments performed in a virtual circle. So that should result in the number of incidents decreasing. And we'll see in a moment if that was actually the case. So the positive approach of Welsh Government and NHS Wales clinicians working collaboratively to improve patient safety. We've presented it in the countries in the UK, and it's been recognised as good practice. We demonstrated a standardised practice with the implementation of the amended All Wales medication chart in 2016, which has led to an increase in the number of assessments undertaken in all Welsh hospitals. And this is identified as a key process step that can lead to a reduction in HATs. So on the left-hand side, we started the process with the All Wales Steering Group in approximately 2014, and we started reporting in 2016. So from 2016 to 2021, as you can see, there has been a decrease in the number of potentially preventable HATs. And that figure is taken from the number of reports that have made into Welsh Government over that period of time from all of the health boards. So that, to me, speaks volumes. It shows that the work that we've done over the past 6 years or 8 years has demonstrated a degree of success. And on the right-hand side, this is the proportion of patients with VTE risk assessment on the medication chart. Now, I'm sorry, it's very small. As you can see, up until 2016, the figure was between 50 and 60%. But in 2016, when we added the VTE prophylaxis tool onto the medication chart, there is a gradual step up to 2018-19, where it's continued to climb. And I can tell you that I looked at the figures for 20 to 22, and the figures are in the region of 90 to 95% for the completion of the risk assessment tool on the medication chart, or the thromboprophylaxis box on the medication chart. So looking at the compliance and processes, this is just an example of one of the health boards, and this was ABMU. On the top graph, which is the blue sort of shark's tooth sort of line, that was the number of patients that were identified as having potential hospital-acquired thrombosis. These were the patients who were developed a clot either during their hospital admission or up to 90 days post-discharge. The line below it then, with the red and blue, and again, in ABMU, we started collecting our thromboprophylaxis data in 2012. But when we introduced the root cause analysis in 2014, things had started to sort of improve more significantly then, following the one-day inquiry, recommendations that were put in place. And as you can see by that, the red and the blue line demonstrate the risk assessment on admission is the red line, and the blue line is a reassessment tool that was implemented in ABMU Health Board, which nurses completed. And when patients came to the ward, the nurses would carry out a daily reassessment. And the first question on the reassessment is, has the patient been risk assessed on admission? And if they hadn't, then nurses prompt the clinicians then to complete that risk assessment, and they keep prompting them until they do it. So we found this was a very good method to improve the uptake of the risk assessment. And again, this was up until 2000, this one is 2015. That was just because it was a snapshot that was taken then, but that figure has continued to move along up in around the sort of 90 to 95% sort of feature. So it's been really successful. As you can see at the bottom, this table or this dashboard shows VTEs by speciality. So you can look at where there were particular areas where there were more VTEs than others, and also by site. So again, you could see where there were areas where you perhaps wanted to go and look more closely at a particular area. So this dashboard was very useful. So again, looking at some of the results, and again, you've got the red and the blue line on the left there, that shows the increase in the uptake of thromboprophylaxis on admission, and the uptake of reassessment by the nursing staff on the wards, which again, quite linear, and that was going up until 2018. So as you can see, those figures were up in the sort of plus 90%. And at the same time, the green line showing the downturn in hospital-acquired thrombosis. So that was interesting. And then in the Nyman Bevan Health Board, again, a very nice chart showing that step up in 2016 when the medication chart risk assessment was included, and that step up then to show the improvement. And again, that was up to 2018, but looking at those figures now, they're still running along around 90 to 95%. So that's been really successful. So the Exemplar Centre, I'm not going to harbour too much on this because Christine Welburn is going to touch on this, but as you can see, the first Exemplar centres were in the Princess of Wales, Maesteg General and Neath Talbot, followed by success in Betsy Cadwallader, with the Ysbyty Glan-Clwyd and Wrexham Myler being granted status. And the HAT steering group is well placed to provide support to other NHS sites and advise them on how to gain VTE exemplar status in the future. And the experience gained by the existing sites will prove invaluable to future applicants. And as I said, when the steering group meet, we share examples of good practice, and we always bring along what we see as being our areas of concern. And one of the biggest issues of concern that I think it is the main issue of concern is where staff, nurses on the wards haven't signed to say that they've given a patient their thromboprophylaxis. And this is, been across Wales sort of the biggest issue that we've found. And certainly through the pandemic, with nurses, agency nurses coming in, bank nurses coming in, staff moving around, it's something that Welsh Risk Pool have looked at to look at, if there has been an increase in the number of VTEs during that period of time, and I'm sure they'll report on that at some point in the future. But it's been really useful to be able to get together and look at ways that we can address these situations in a collective manner. So again, National Thrombosis Week, which we're all sitting here enjoying. We used to have our our National Thrombosis Week meetings for many years, which was supported and organised by Thrombosis UK. And then in 2015, myself and Marilyn, supported by Joe, developed our own conference, which we held in Cardiff, which was at the beginning of May, and they were very successful. We had some amazing speakers. We had Andrea Cohen, we had the Minister for Health came and opened one of the meetings and spoke, and Professor Simon Noble, we had Dr. Razaf Ali Khan, with some excellent speakers. And unfortunately now for Cardiff, we've now moved away from that and joined in with the virtual National Thrombosis Week, which is extended to the whole of the month. And we've gone from having our meetings in a room with maybe 150 other people to the virtual conference under the auspices of Thrombosis UK, and getting audiences of somewhere in the region of 1,500 people joining in the conference. So I think this is the way to go, and it's certainly been extremely successful thanks to the work by people like Joe. So we've seen in Wales, the work that we've done has been presented in posters and presentations nationally and internationally at events including World Safety Congress in 2015 in Madrid, ISTH Congress in Berlin 2016, the Royal College of Nursing Centenary Conference a year later, IHI Quality and Safety in Healthcare in Glasgow 2019, ISTH Congress in Melbourne, Australia 2019, ISTH in London, which is in July, if any of you are looking to go or join into a good conference. There will be posters and presentations taking place there by members of the All Wales Steering Group, and examples of successful HAT prevention initiatives from Wales have also contributed to ongoing work in Northern Ireland and Scotland. So thrombosis work presented globally has really put Wales on the world map. So in 2018, following the publication of the revised guidance on prophylaxis, which was NICE Guidance 89, the All Wales Steering Group led the development and agreement of an All Wales thromboprophylaxis policy. The Thrombosis Committee of all NHS health boards came together to ratify this policy at the end of 2019, and it's believed Wales is the only UK country to have done this. In fact, I think I've been putting my neck on the line. I think we're probably the only country in the world that has got a national policy that is followed by all health boards in that country, and in this case it being Wales. So accumulation of work undertaken in Wales over the past 5 years has seen 2019 Anticoagulation Achievement Awards held in the House of Parliament, where 4 of the 10 categories were won or commended by Welsh health organisations. So there was CTM, Betsy Cadwallader, Swansea Bay, and there's Professor Simon Noble giving Mike Feely, who was our Public Health Wales, and I should mention Mike has retired now, but he was such a driver in the work that was done in Wales, and he was receiving his achievement awards there. So it was a very proud day for everybody who attended. So the effects of change have been impressive in terms of the increase in VTE risk assessment uptake and the downturn in the number of potentially preventable HATs since the beginning of the Welsh Assembly Government HAT and Root Cause Analysis project. And I just want to show you this graph again because we're really proud of this in Wales. So the downturn in HATs and the uptake in risk assessment, I won't dwell on it. So the lessons learned, collaborative working between governments and clinicians can result in sustainable nationwide improvement. Some organisations that have identified HATs that were potentially preventable and pinpointed areas of learning so that future delivery can be improved. To ensure that all organisations can benefit from this learning and to prevent similar incidents going forward, details of individual health boards' lessons learned and corrective actions are provided in text and disseminated in an annual report delivered to all HAT leads. The submission of incident reports has generated discussion amongst consultants, resulting in improvements in prescription and documentation. So the future of the steering group, the group has achieved all of the objectives set by Welsh Assembly Government following the one-day inquiry in 2012. And over that time, a number of other HAT-related issues have been identified and addressed by the group. These issues have included updating the All Wales approach to VTE prevention when the new NICE guidance is published. So the tool that we developed will automatically update. So we don't have to keep going and changing it, which is really useful. And the advice and guidance provided by the group has been valued by Welsh Government and the wider NHS Wales community. And it would be advantageous for this group to continue for the future. But unfortunately, in October 2021, the NHS delivery framework for 21-22 did not include the following measure: the number of potentially preventable hospital-acquired thrombosis. And as the saying goes, all good things must come to an end. But that's not the end of the story. And Marilyn is going to continue after this presentation to tell you where we're going next. So I'd just like to share with you, these are the members of the Hats or Wales Steering Group as we were when it came to an end in 2021. And as you can see, these were present and past members. And all of these people did a wonderful job and moved Wales into the position where we are today. So it leaves me to say, diolch yn fawr, thank you very much. And I'm now going to hand over to my friend and colleague, Marilyn Rees. Marilyn, who is the DVT clinical nurse specialist in University Hospital Wales, has been involved in thromboprophylaxis care for probably 18 years. Is that right, Marilyn? Maybe 20 years. And we've worked together tirelessly with other members of the group to improve the uptake of thromboprophylaxis risk assessment. Marilyn's an ambassador for Thrombosis UK and has presented posters around the world and has been a key figure in the HAT steering group and the drive to improve thromboprophylaxis uptake and the HAT downturn in Wales over the past 20 years. So over to you, Marilyn. Thank you very much.
Thanks, Andrea. Hope everybody can hear me. So as Andrea alluded, we are having to embrace some new approaches because of changes in the reporting structure to Welsh Government, really. Bear with me while I try and move on. So previously, as Andrea mentioned, the process of linking HAT to a tier 1 priority and the formation of the All Wales HAT steering group proved to be very successful. But as she said, in October 2021, the NHS delivery framework for 21-22 didn't include the measure for wanting us to give them the information regarding the number of potentially preventable hospital-acquired thrombosis. So as a result of that, there's no longer a requirement to submit HAT data to the Welsh Government on a monthly or a quarterly basis. As organisations' overall commitment to delivering high-quality value services, it was suggested that we were needing to turn to sort of local reporting arrangements to be discussed at quality and safety meetings to make sure that we were attaining internal board assurance. This wasn't really good news for us. So coincidentally, around that time, the Welsh Risk Pool were wanting to look into VTE in a sort of wider review. They were looking at the recognition of VTE as well as what we were particularly interested in, the hospital-acquired thrombosis. And a group within the Welsh Risk Pool commenced an audit in all the Welsh hospitals, looking at the uptake of thromboprophylaxis risk assessment, as I said, as part of a wider review. This was because the National Learning Advisory Panel had noted an increased numbers of redress and clinical negligence cases that were related to venous thromboembolism through their sort of thematic analysis. And the cases they felt were in relation to either failure to recognize the symptoms and the signs of venous thromboembolism in a patient presenting to hospital, or the failure of adequate risk assessment when that patient or a patient was admitted to hospital and then they subsequently developed a VTE. They did recognise that the VTE numbers generally had decreased, but they still felt that the cases caused a significant burden on the NHS in Wales. They made contact with members of the All Wales HAT Steering Group to discuss the findings of the audit, and a number of the areas of concern were discussed with us. One particular concern, although they recognised the use of the All Wales medication charts, the box on that we've had for thromboprophylaxis was in use, they felt that the lack of a full documented risk assessment was a specific concern. They felt that that might lead health boards in Wales involved in any sort of VTE litigation cases to be at risk, really, of being able to adequately demonstrate that appropriate risk assessment had taken place. And they also felt that there was potential for introducing better learning opportunities to change approaches to assessment and therefore reduce the risk. As Andrea's mentioned, in Wales for some considerable amount of years, we've been having to come up with innovative and imaginative ways to increase the uptake of thromboprophylaxis in Wales to reduce the incidence of potentially preventable HATs. We didn't have the fortune of having sequent targets, so we had to be a little bit more imaginative. One particular area of interest was always about how to improve in-house teaching and training for clinical staff. Health boards across Wales have different approaches to thrombosis preventing education. Some of them have more dedicated staff, some of them rely on in-house training. So there's quite a variance really in both the content and the delivery. Following discussion with the All Wales HAT Steering Group, the Welsh Risk Pool were really interested in new approaches, and they supported the idea of an education programme that we were looking to put on ESR, which would include teaching HAT prevention for all patient-saving staff. In addition, teaching in HAT prevention and treatment for all clinical staff, teaching in the signs and symptoms and diagnosis of a VTE for all clinicians, and that staff undertaking the teaching would be required to achieve a pass mark, which would be set and agreed by the All Wales Steering Group. There are limitations to the Welsh Risk Pool approach. They can't mandate this, but they can help us set achievable standards, which we can review regularly. And they can work directly with the All Wales HAT Steering Group, and will become affiliated to the Welsh Risk Pool, and therefore still be indirectly linked to the Welsh Government as well. We can produce annual results for the uptake of thromboprophylaxis across all the 7 Welsh health boards and Velindre, so ensuring that thromboprophylaxis remains a key figure on the stage. And we can produce annual results to demonstrate the number of potentially preventable HATs in all 7 Welsh health boards and Velindre as well. And the WRP, the Welsh Risk Pool, will plan to join and host the All Wales HAT Steering Group so that they can keep up to date with developments, innovations and potential issues and help us really develop further. They're looking at 5 standards. These are still awaiting wider approval, so these aren't set in stone in any way at the moment. But what they want to see in place is that all health bodies within NHS Wales adopt the All Wales thromboprophylaxis policy, and that all clinical staff undertake All Wales training. As I said, there is something going to be developed to be put on ESR, but there's still some discussion about how that's going to go forward. And we'll also include not just HAT training, but also recognition of symptoms of VTE in those patients coming into hospital. All patients receive a documented VTE risk assessment using a Department of Health style risk assessment tool or similar on admission as part of the initial patient clerking, and an All Wales checklist for the investigation of HAT is developed in order to maintain a uniform investigative approach across NHS Wales. VTE risk compliance data and all HAT data is shared at appropriate health board governance meetings, which is in place generally speaking now anyway. The Welsh Risk Pool are currently working with the All Wales HAT Steering Group on developing the individual teaching programmes with a plan that they'll be accessed on ESR, with a hope that this then will be rolled out in the autumn of this year, and provision will be made for both English and Welsh. And that's my lot.
Thank you very much, Marilyn. It's very exciting time for us at the moment, because when Welsh Government ceased to recognise our Tier 1 priority and removed it, and basically, well, we were no longer associated with Welsh Government, we were in a bit of a quandary as to where we were going to go next and what we were going to do. So the work that we've now been doing with Welsh Risk Pool and the potential of putting our teaching programme onto ESR with the 5 standards that Marilyn's just gone through means that it's taking the education side of things a step further. It's also improving the education for all of our clinicians and our face-to-face staff who are non-qualified. So it's an education tool across the board, and it's also widening the education from trauma prophylaxis to recognition of a potential DVT or PE, and how we go about doing, carrying out that recognition. Because one of the things that Welsh Risk Pool found was that patients who came in with symptoms failed to be diagnosed appropriately, which then went on to lead to a claim. And so we need to improve the education of our clinical staff so that they are far better equipped when patients are attending A&E departments, or are in fact in inpatient and develop symptoms, so that they can be recognised and treated appropriately. I think just while we're sort of ahead of time, there is a question that has been asked, so we can answer that. So this is from Valerie Pollard, and Valerie's asking the question: do you have any recommendations for HAT assessment on discharge from hospital? Do you have any standardised patient information leaflets regarding symptoms of VTE post-discharge? Okay, well, thank you very much for your question, Valerie. I can say for myself that patients who come in for particular surgeries, whether that's orthopaedic or general surgery, we are giving patients information for when they go home, which identify should they get pain or, in their calf or chest pain, difficulty breathing, putting the emphasis on the potential that that could be a VTE, and that they should seek guidance from either a GP or from A&E. Also, there is an information leaflet that we give out, which is available on Thrombosis UK to order, which explains the different types of thromboprophylaxis, the rationale behind thromboprophylaxis, what to do when you go home regarding drinking, mobilising. Although over COVID, it's probably not been as easy to manage that every patient has been given that, and I put my hands up to that, and somebody threw out 4 boxes of leaflets when they wanted the office they were in, So we've all faced difficulties through the pandemic, and for me that was one of my big difficulties. But yeah, we do have some information. But what about you, Marilyn? Or is there anybody out there, Wales? I know Christine's listening in. Have you got anything, Christine? If you could put it on the Q&A, or Simon, have you aware of anything from a cancer point of view?
Well, we did have, we did actually produce an All Wales information leaflet, which was translated into Welsh as well.
Of course, yes.
And I believe that is still available on Thrombosis UK website.
It is, yeah.
I think my advice for anyone would be to go on the Thrombosis UK website. There's a lot of resources there that are being used by other hospitals, trusts, health boards. So don't try and reinvent the wheel. There's a lot of expertise there, and these things are being put on there with the intention that they can be shared. So I think that's the best way forward there.
Yeah, I think that leaflet, oh, sorry, Joe, I think that leaflet was actually given out for patients who come to pre-assessment. They're given it with all their other information. And I think there's an IDO leaflet as well that can be used. So yeah, Simon said there's a lot of information out there. So rather than going off and trying to reinvent something, just have a look what's available. Right, sorry, Joe.
I was just going to say, Thrombosis UK also this year produced some new leaflets which are around people being admitted or discharged into hospitals. So they fold like this, so little square boxes, almost like a credit card, and open up with information about the risks and the signs and symptoms. Now, these are available on the website, they can be ordered, but also you can download them. And I know we're working with one hospital to make them just into simple sheets, which they find easier. So we can work with you to make it something that will work for you using this information.
That's excellent. Sorry, I should have mentioned that because I've got a box of those under the table to give out, so I do apologise. But yeah, it is a very good leaflet and it fits in your pocket, so it's really handy. Christine's just come back to me, Christine from Cadwallader University Health Board, and said that they have Welsh and English information in Wales. Like other parts of the country, we have bilingual information that we give out to patients, and they also use the IDO form, the information leaflet, sorry.